All right. Welcome everyone. We are going to get started because 6:30 my time, 5:30 Central. Um, my name is Carrie Harvey. I am an emergency medicine and critical care physician at the University of Michigan.
I'm Colin McCluskey. I'm a EM doctor and a critical care intensivist in the cardiothoracic ICU at University Hospital's Cleveland Medical Center.
Hi, gang. My name is Matt Stull. I am also a emergency physician as well as an intensivist at the University Hospitals in Case Western in Cleveland.
Yes, so the three of us, we've remained friends for a long time. We were the first three emergency medicine anesthesia critical care fellows to go through the training program at University of Michigan. And we've given a version of this talk mostly, I think, every year since we graduated. So we're really excited that you've joined us this evening for EBR, evidence-based resuscitation. And in the didactic today, we're going to be reviewing some notable critical care trials from the past year that were published outside of emergency medicine journals and therefore may have been missed. So we have no conflicts of interest, but want to emphasize that we're presenting our opinions. And so we, of course, encourage you to read the literature yourself. And before we dive in, a couple of things. First, we are going to have 3 quick polls throughout the talk, and we would love your participation to help inform some of our discussion today. The other thing is the 3 of us will be pretty active in the chat. So please feel free to engage, or you can just sit back and enjoy our banter. I'm sure there will be some of that. And then lastly, we are going to have a QR code on the very last slide. It's going to link to a box folder that's going to contain articles and associated reading for the talk today. So please do not feel the need to frantically take screenshots during our presentation. Okay, so we're going to start with 3 trials about hypoxic respiratory failure, and I want you to be assured that today is a COVID-free zone. And so we are going to start off with a poll. What vent settings do you pay most attention to in the emergency department? Colin, what's your answer?
I can't pick just one. It's like picking a favorite child. They're all very near and dear to my heart. But tidal volume, probably, if I had to pick.
All right. It looks like that's kind of the results that I'm getting as well. So the majority of people that answered the poll, 64% answered tidal volume, which is great. I think that reflects the fact that all of the research about low tidal volume ventilation has taken root and we are paying attention to it. Some of the talks today, though, I'm going to actually do them in the hopes that we focus on some of our other ventilator settings as well. So let's jump into it. Okay, so first, we are going to review the HOT ICU trial published in New England Journal last year. And the background for this trial, so we know that hypoxia is bad. We know that hyperoxia can be bad, but what we don't know is the optimal oxygenation target that balances the risks of each. And this is apparent because we have no clinical practice guidelines to address this question. And there's been a flurry of study recently trying to find this optimal target, but they've all had conflicting results, which has really just made it more confusing. So, for example, one of these trials found a mortality benefit with a lower oxygen target. Another one found no difference between targets. Another one found an increased rate of mesenteric ischemia with the lower oxygen target, and it was actually stopped early for safety reasons. So all of that leaves us, clear as mud. So enter HOT ICU, which kind of sought to cut through all this conflict and answer the question, does a lower oxygen target reduce mortality in acute hypoxemic respiratory failure? So this was an RCT. It enrolled about 3,000 patients, and you were included in the trial if you were admitted to the ICU with hypoxic respiratory failure, which was defined as FiO2 of 50% or greater on a vent, or if you were not intubated, at least 10 liters of oxygen. And the baseline groups were very similar. They were a pretty sick cohort, actually. About 12% had ARDS, half were on pressors, and then, as you'll see in the next slide, there was a pretty high mortality rate in both groups. So the intervention was a lower O2 target. So they define this as a PaO2, so from an arterial blood gas of 60 millimeters of mercury, and the control group had an O2 target of 90. And then, as I mentioned, the primary outcome was 90-day mortality. So for the punchline, for that primary outcome, no difference between the groups. Okay, you can see there at 90 days after randomization, the lines have converged. The probability of survival was 0.6, which meant that both groups had about a 40% mortality rate. There was also no differences in the myriad of secondary outcomes that they studied. Importantly, that included some serious adverse events, one of which was mesenteric ischemia. So that again was different from that other trial that I mentioned on the prior slide. An important thing to note, even though the study was designed to target a PaO2 of 60, the median PaO2 met by the intervention group was higher. So it's that blue line there. You can see that median PaO2 was 70. So really this ended up being a trial comparing 70 to 90, not 60 to 90. So the authors concluded the following: targeting a PaO2 of 60 did not reduce 90-day mortality, but nor did it increase rates of serious adverse events. So the takeaway from this trial for me is that targeting a PaO2 range, like 60-ish to 100-ish, is safe, and it balances those risks of hypoxia and hyperoxia. Unfortunately for us as emergency physicians who don't always have the luxury of serial ABGs, the study did not give any kind of SpO2 target. However, it is recommended that after application of oxygen therapy, either invasive or non-invasive, you should get an ABG 30 minutes later to ensure that your blood gas is where you want it. You can imagine intubating someone. So at least where I work, everyone gets put on FiO2 100% after intubation. It's just part of our protocol. You can imagine someone who has like healthy lungs, who's intubated for altered mental status, their PaO2 might be 500, and you don't want to let it ride there. So that's why you check the ABG. Alternatively, you can imagine somebody with sick lungs, their PaO2 is 50, and that's a person you're really working hard to get upstairs to your ICU quickly, or calling for help if you do have to board and manage them in your ER. Per usual, one trial breeds another. So upcoming through ANZIX, which is a big critical care trial group in Australia and New Zealand, is this trial called MEGAROX. So this is going to be a huge multinational trial. They are going to enroll 40,000 patients. So the one I just reviewed, hot ICU, 3,000. They're going to enroll 40,000 patients, myriad of diagnoses, to try and bring some closure to this important question. Okay, moving on. I'm really excited about this study. This is an ED specific study that made it into CHEST back in February. So for context, a few years ago, there was this study called Love ED. It was published in Annals of Emergency Medicine in 2017. If you have not read it, go read it. It's a great study. It found that implementation of a lung protective ventilation strategy in the ED was feasible and improved outcomes. And so this current study was similar in that it looked at the association between ED lung protective ventilation and patient outcomes. So this was a retrospective analysis of about 4,200 patients across Canadian emergency departments, and adult patients who received invasive mechanical ventilation of any duration in the ED were included. And then those patients got divided into two groups. So those who met lung protective ventilation, which was defined as a tidal volume less than 8 cc's per kilo of predicted body weight, and then those that didn't. And the primary outcome was hospital mortality. There was also a variety of secondary outcomes, including, interestingly, hospital cost, which often is not included in a lot of critical care mechanical ventilation trials. Okay, so first things first, of those 4,200 patients included in the study, how many do you think met low tidal volume ventilation? So the answer in this study was 58%, which is okay. It's actually fairly comparable to other studies that have investigated the incidence of low tidal volume ventilation, but it's certainly not what we want when we know that this is so effective for lungs. So for that primary outcome of hospital mortality, the 58% in that LPV group, they did have decreased odds of dying, adjusted odds ratio 0.91, when compared to those that did not. And all of the secondary outcomes were also better in those patients that met LPV. So specifically, they had decreased odds of developing ARDS. They had shorter duration of mechanical ventilation by about 1 day. They had a shorter hospital stay by about 3 days. And then unsurprisingly, their total hospital costs were less, about $6,000 less. So the authors concluded that use of LPV in the ED was associated with important patient and system outcomes, including decreased mortality. So I really like this study because it aligned with many of the results from Love ED. And this just adds to our pool of evidence that LPV in the ED really matters. It's important to recognize the study was retrospective. So the finding of decreased mortality is association, it's not causation. But still, my takeaway is that we as emergency providers need to promote the regular use of LPV in the ED. So obviously that's going to include education, right, of ourselves, of our trainees, of our ancillary staff on its importance. But you are only one person. And so for this to really take root, you need protocol development to increase adherence and standardized care amongst everyone in your department. So anyone out there who's listening and is interested in operations, if there's any trainees that need a good scholarly project while they're in residency, if you're interested in this and your institution does not yet have a mechanical ventilation order set for the ED, go get to work. Okay, implementing an order set or a protocol is a low-cost intervention that has potential for major side effects. All right, one final study on hypoxic respiratory failure. So unlike ARDS, we don't have a lot of research surrounding optimal PEEP strategies for non-ARDS patients. So this study sought to answer the following question. In non-ARDS patients, is a lower PEEP strategy non-inferior to a higher PEEP strategy in regards to ventilator-free days? So as a really quick reminder, ventilator-free days, it's a composite outcome over 28 days of death or liberation from the ventilator. So more ventilator-free days is a good thing. That means you are not dead and you're off the ventilator. So this was a big multi-center RCT, about 1,000 patients who were intubated in the ICU but did not have ARDS. And then patients were randomized to a PEEP strategy. So there was a low PEEP strategy, which involved minimizing the PEEP as much as possible to maintain SATs of 92 to 96%. And you could go all the way down to 0 PEEP. That was fine. It was encouraged. The high PEEP strategy involved letting patients just kind of like cruise along at a PEEP of 8. And again, primary outcome was number of ventilator-free days. All right, punchline. No difference between the groups regarding ventilator-free days. So the authors concluded that a low PEEP strategy was non-inferior to a high PEEP strategy. Here's where I disagree a bit with the paper conclusion. The authors added this sentence to the abstract conclusion. These findings support the use of lower PEEP in non-ARDS patients. And I disagree pretty strongly with that conclusion. And I'm going to give you 3 reasons why you should not target a PEEP of 0 in your non-ARDS patients. So first of all, this study actually compared a PEEP of 4 to a PEEP of 8. Very few patients ever really got down to a PEEP of 0, and if they did, it was not for long. So a blanket statement suggesting we should be trying to minimize PEEP to 0 in everyone is a reach for me. Next, only 30% of patients who were intubated had respiratory failure. So the remaining 70%, the vast majority, they were intubated for other reasons, things like airway protection or planning to remain intubated after a surgery. Those patients they're going to get extubated for non-respiratory reasons, right? They're going to get extubated when the drug they ingested wears off or after they've proven their stability after surgery. They're not going to get extubated because we made these like minor adjustments in PEEP. So it really shouldn't be surprising that there was no difference between the groups, considering the study targeted an endpoint of ventilator-free days in patients without ventilatory failure. Most importantly, you had to dig through the article a little bit to find this. One of the secondary outcomes was need for rescue therapy. So that would be things like a recruitment maneuver, prone positioning, needing to bronch somebody because they have a bunch of atelectasis. And more patients in the low PEEP group required rescue therapy. Then if you look in the supplementary material, you see these graphs. The low PEEP group is the blue line. They had higher driving pressures and lower PF ratios, which suggest de-recruitment of lung. So combining some of the limitations of the trial design and the fact that the patients in the low PEEP group needed more rescue therapy, I will not be using a lower PEEP strategy in my non-ARDS patients. I'm going to keep sticking with what I already do, which is a PEEP of 5 in most patients, and then consideration of PEEP of 8 for usually patients with morbid obesity and large chest walls. So to review again, first, ABG 30 minutes after intubation or non-invasive ventilation initiation with the goal PaO2 of 60 to 100-ish. Develop that mechanical ventilation order set to maximize adherence to LPV. If you already have one, make sure you're using it, and consider doing a QA to see how your ED is doing in all this. Maybe you're better than that 58%. Finally, PEEP of 5 to 8 is a good place to start for your non-ARDS patients. So with that, I'm gonna ask Colin if there's anything to address right away. Otherwise, we can switch topics, and I'll pass the mic over to Colin.
Yeah, no, we had a little bit of banter in the chat talking about ease of trying to actually measure height in order to get lung protective ventilations using tape, like a tape measure. Is this something you cognitively offload to your RTs, or are you checking them? How do you ensure that all these patients on your shift are getting what they need as far as lung protective ventilation?
Yeah, that's a really good question. So the Love ED trial that I referenced before, part of that trial was like a before and after trial of before and after the introduction of a mechanical ventilation order set. So what they did in this study is they included RTs with a tape measure, measuring every patient once they were put on a ventilator. That was just part of the order set. It was something that had to get checked in order to move on. And they did prove in that study that it was feasible. We did something similar at where I work at U of M. We have a mechanical ventilator order set that we've had for a couple of years, and it's the same thing. We have we use Epic. We have hard stops, and one of the hard stops for the RT workflow is that they have to go and measure with the tape measure and enter it into the computer. So that's how we made it work where we are.
Yeah, I think protocolizing it, as you said, or having some sort of workflow to confirm this that fits your shop. Obviously, if you come from a big resource place like U of M, that'll look different than if you're at a critical access place, but cognitively offload it to make sure, because this moves the needle. I agree with you. So we're going to move from hypoxemic respiratory failure, non-COVID, thank you, Dr. Harvey, to cardiac arrest. And quickly, I kind of want you folks to reflect on your ED practice, picture yourself in your resuscitation bay, and of all the folks that come in with out of hospital cardiac arrest, how many have you resuscitated, got return of spontaneous circulation or ROSC, and got them admitted to the hospital? Interesting. We have some very good resuscitationists here in this room. If you all would like to work and show me a thing or two about a thing or two, that would be fantastic. All right. So we have a bunch in, and I'll kind of share the results for a moment. So it looks like most folks are in this 5% to 20% range. And to be honest, if you look on the CARES registry, The all-cause mortality, or sorry, the actual survivorship is 10% for all comers without a hospital cardiac arrest. And obviously that's not a lot. And it can certainly breed a sense of nihilism when these folks come in. And if you've had death 19 out of the previous 20 times, it's going to be hard to get really excited about doing everything you can and really selling out for this patient population. So the nice thing is that the details matter in cardiac arrest, especially arrest details. If you have a shockable rhythm, VF, VT, it's a witnessed arrest, then that actual, not only survivorship, but survivorship with a good neural outcome, like a CPC of 1 to 2, is actually 30%. And it's in this population of witnessed arrest and a shockable rhythm that the two papers I'm going to discuss are going to directly address. So the first study is the Antarctic study. This was in 2019 in New England Journal of Medicine. And it asked the question, if we give antibiotics for 2 days following out of hospital cardiac arrest with those features that we talked about, will it prevent ventilator-associated pneumonia? And in fact, that's what they found. Not to bury the lead. So this was an RCT, 16 ICUs in France, double-blind, placebo control, everything you want for the internal validity. And it included folks that were over 18 that had shockable rhythms and that were then cooled upon return of spontaneous circulation. So this is kind of that niche group that has a lot of favorable peri-arrest characteristics. They excluded non-shockable rhythms in hospital cardiac arrest, or this was France, if you aspirated a huge baguette, you weren't going to be eligible for the study because it was unlikely that the unison that they were going to give you was going to prevent a aspiration pneumonitis. They recruited about 200 folks, and the average human, to give you an idea, was about a 61-year-old male, witnessed out of hospital cardiac arrest. It was VFib as the initial rhythm, and they had a low flow time of about 20 minutes. So I'm not sure what your shop and what the patients that you're resuscitating look like, but that's who this study was evaluating. They compared either placebo, good old normal saline, 3 times a day for 2 days, or actually like IV ampicillin clavulanate or augmentin. We don't have that IV here, but basically a unison or amsulbactam is what they got 3 times for 2 days. Primary outcome, rate of early ventilator-associated pneumonia in the first week, where we think antibiotics are probably going to be helpful. Ultimately, it almost halved the incidence of this. The hazard ratio is 0.53, so a 47% reduction in actually having this primary outcome. For a couple squirts of antibiotics, that's kind of moving the needle a bit, like a good amount. Once again, our goal in this population is to get them out of the hospital back to independent living. And if we can take away an iatrogenic complication, ventilator-associated pneumonia, I think that's an easy ask for the ED practitioner. Now, only 200 patients, they did not actually show a mortality benefit. However, there was no signal for harm, no increased risk of C. diff, no increased risk of other nosocomial infections. Actually did like gut flora swabs. There weren't a ton of MDRs now swimming around. So a pretty beneficial study. Nicely, similar to Dr. Harvey's point earlier, that a cost consequence analysis done here found that it also saved money, even with the survivorship bias in the antibiotic group. So stops pneumonia, saves your hospital money. That's a value proposition that most of us will take as an ED intervention. All right, moving from an easy, can take the shift tomorrow intervention to one that'll take a little bit more planning is creating robot people in this out of hospital cardiac arrest milieu. And this is ECPR. For those of you who don't know, that's veno-arterial ECMO cannulated during arrest, hoping to buy time. That's all ECMO is time with a price. In this case, they're trying to select folks that likely had a coronary lesion. We put them on ECMO, they get enough time to get to cardiac cath, the balloon goes up, coronary flows there, and the patient does better, all right? So this was a single center RCT done at the University of Minnesota. And once again, niche population of cardiac arrest, witnessed arrest, refractory VFVT that I'll define for you in a moment. But 18 to 75, so pretty broad age criteria. It had to be witnessed. About 80% of these folks actually got bystander CPR. So they're cherry picking the best cardiac arrest that you can. Refractory VFVT was 3 shocks by EMS. If you didn't get ROSC, you're going to come to the cannulation hospital and undergo randomization. They also needed an EMS trip from the arrest location to the hospital of 30 minutes. That's not downtime to hospital, but actually like you could navigate through your city 30 minutes from the arrest to the cannulation center, all right? Exclusion criteria of note, any other arrest type. This is not trauma, this is not ODs, drownings, anything like that. They're just selecting cardiac arrests. And anyone that was a nursing home resident. ECMO and is a system of care, and it's a lot of expense. You're only going to expend it on the folks you think have a baseline fitness to tolerate it. So if you're in the nursing home, you're excluded. All right. What they did in this trial is redesign their entire cardiac arrest process in their center. This gentleman is having a cardiac arrest. He collapses, it's witnessed, the bystander initiates CPR and calls EMS. EMS arrives, does ACLS, shocks 3 times. They're still in VF or VT. They then transport to the cannulation hospital. At that point, they were either randomized to ACLS and the EED with all you find folks who are pushing fast and hard and doing evidence-based resuscitation in your resuscitation bays, or they went to get eCPR in the cath lab, all right? In the cath lab, they would draw an ABG before cannulation, and if the metabolic milieu was favorable, lactic acid less than 18, end-tidal CO2 over 10, pH over 7, they would then proceed to peripheral cannulation for VA ECMO. Their primary outcome was survival to hospital discharge. And the robot people did a lot better than the ACLS folks. In fact, they're almost 40% survived a hospital discharge, and all of those folks had a CPC of 1 to 2 at 6 months, which is I can live independently and shower, feed myself, all those things. The outcome that patients are really honing in on. I will bring some attention to that the ACLS group, 6%, oof, that's pretty rough. As I said, in the CARES registry, it's about 10%. And reflecting on the polling, that seems a bit low based on our observed experience, especially in this cherry-picked population. Right. So eCPR, 40% survival with good neuro outcome. This should be happening everywhere, right? You should be banging on your chair's door, knocking down the EMS director's door and saying, why can't we bring this to our system? This is a game changer. Not yet, all right? Couple things to know. One is that this was stopped early by the Data Safety Monitoring Board. They did a Bayesian adaptive trial, and basically, because the difference in the mortality, their primary outcome, or survival to hospital discharge was so great, it actually was stopped at the first interim analysis after 30 people were enrolled. And the mortality was really high in that ACLS group. The CARES registry says shockable VFVT witnessed should have a survival of around 30%. They actually made their power calculation for between 10 and 20%. This was far lower, making it far more likely that you're going to find a positive study for your intervention. And lastly, this was a very mature eCPR system. They actually started eCPR in the University of Minnesota system in 2015. And they actually started enrolling in the study in 2019. They had 4 years to iterate, to do training, to figure out best practices, to get on the same page. This is not something that you can turn around or I can turn around tomorrow and try to deploy for these patients in my emergency department. Lastly, it's not terribly generalizable. If you live in LA, if you live in Chicago, the traffic density is probably going to prevent, that expeditious transport that allows this to be successful. Similarly, if you live in a critical access hospital, this is going to be a non-starter. You're not going to have the resources for it. So it's only going to be select centers in select areas that can do it. So my take-home points from the 2 papers in shockable rhythms, witnessed out-of-hospital cardiac arrest, is give antibiotics. It can prevent ventilator-associated pneumonia, and that's going to be a patient-centered outcome. Also will save some money for your system. And eCPR is a future of cardiac arrest. We still have to figure out the best way to deliver it, how to generalize this to other systems, and how to train and cannulate and do all those things in the most expeditious way. All right. So Dr. Stoll, I see a ton of stuff in the chat. I wonder what was bubbling up.
I mean, I think a lot of folks were talking about the challenges of the pre-hospital setting. It's clear that some folks are obviously involved with their local sort of pre-hospital group. So, you know, how does Minnesota's sort of pre-hospital experience compare to what is available out there broadly for us?
Yeah, I mean, so their actual system now, they have 3 different cannulation hospitals and 12 different EMS agencies that they've all had on the same page. They've done training, they've done translational simulation from dropping a person in a park, redesigning the 911 system that they actually dispatch a cannulation group to a cannulation hospital. It's an entire undertaking. In fact, it was in eClinical Medicine, the Minnesota Resuscitation Consortium actually published everything that went into building this, and it's far more in depth than what the ARREST trial actually speaks to. So this was a huge coordinated effort in the entire chain of survival, from the EMS folks all the way to the intensivists and the post-ROS care.
Yeah, no question that this seems like more of a "it takes a village" sort of mantra when you talk about an eCPR program than just it being its own sole intervention. Well, great. Well, I'm going to round us out, folks. First and foremost, thanks for sticking around for an entire day of virtual conferencing to talk a little bit about some EBR, evidence-based resuscitation. I have the distinct pleasure of getting to talk about everyone's favorite topic, which is COVID. No, I'm kidding. Don't walk away. We're not going to talk COVID. We're over it, right? We're not going to talk about it. 2020 was enough about that. Let's talk about some other interesting things that happened in 2020 besides COVID. So we're going to talk about what I think is one of the favorite topics of every ED doc, which is
You're muted.
Am I unmuted now? There we go. Yeah, someone unmuted me. Sorry. Let's get started with a little poll. I want to ask you guys about when you initiate your massive transfusion protocol, what do you find, which product gives you the biggest bang for your buck, right? Is it red blood? Is it FFP, platelets, cryo, TXA? What aspect of your MTP are you sitting on bated breath waiting to give, because you know that's the thing that may turn this patient around? So far, oxygen carrying capacity often wins the day, doesn't it? There's someone that loves those little platelets out there. We'll give it okay, we got 10, 11. So most people love the oxygen carrying capacity. A couple people come in to love the TXA. Carrie, I'm interested in your thoughts. What is your sort of like favorite part of the MTP in your environment?
I mean, I don't see calcium as an option on here, Matt.
It's a trick question. I agree with you. As 3, there's no question as 3 EM intensivists, we all love the best natural ionopressor there is, calcium. I think it's the thing that is most neglected in an MTP protocol, but no doubt, everyone has a little bit of their favorite something to give when people are bleeding. But let's be honest, the beauty of a hemorrhaging patient is it defines emergency medicine, right? A sick patient, super quick, but super, complicated thing that we have to deal with, in, out, that sort of thing. And so there is nothing that makes me feel like an emergency doctor more than actually dealing with a hemorrhage once in a while. So when we think about hemorrhage, I have 3 key questions for you. And, the first one is, in today's world, who doesn't love TXA? I mean, honestly, right? EM tends to be that specialty who falls in love with a couple drugs. Rocuronium, ketamine, now it's TXA. Why? Because realistically, we found with the CRASH 2, CRASH 3, multinational, huge trials looking at mortality in traumatically injured patients that you're suspecting hemorrhage, that TXA actually had a mortality benefit, at least within the first 3 hours. Then along comes the woman trial, right? A woman gives birth and starts having a postpartum hemorrhage. TXA also has a meaningful benefit in these folks. What's awesome is it's also safe, right? In both of these trials, not seeing any effect towards harm in either of these very different patient populations. And then more recently, especially in the EM literature, I feel like every 6 months something comes out about nosebleeds. And while we're not going to necessarily save a life based on treating the nosebleed with TXA, I think we all know that the data seems to be coming down to giving it, whether it be topically, IV, whatever, seems to help these patients stop and rebleed at a little bit of a less rate, depending on what you read. But the question comes, okay, all of these typically are traumatic, if you will, right? There's obviously trauma in the middle. A postpartum hemorrhage in some ways is almost traumatic as the placenta tears away from the uterus. And then obviously, digital trauma is the #1 leading cause of nosebleeds in the country. But what about medical patients, right? What is our favorite medical hemorrhage? It's a GI bleed, no question. And so the HALT-IT trial, I would presume this is probably one that many of you have seen in the Lancet, published last year, looking at high dose TXA. So it was at a dose 3 times the rate that we would typically give in any of these other trials that we've seen, but looking at in this double-blind, placebo-controlled, multinational trial of about 12,000 participants, whether or not patients benefit from this. I gotta say, this is probably one of the most inclusive trials I've ever seen, because literally their inclusion criteria was, do they have a GI bleed clinically, and do you think they might want TXA? And that's all it took for you as a clinician to get them enrolled in this trial, which is really pretty impressive. And then they're looking to reduce mortality as a result of this. But we all know that GI bleed mortality depends on the comorbidity and the type of bleed that it is. And not surprisingly, or well, maybe somewhat surprisingly, quite honestly, since the data says that TXA is just a wonder drug, didn't affect mortality in the least. Not in their primary outcome, which was bleeding within 5 days or death from bleeding within 5 days, or not with any of the other planned secondary analyses that were very patient-centric. Death, rebleeding, a variety of markers throughout their time. Not even the hint of improvement with TXA. But wait, you're going to say to me, right? You're savvy clinicians. Everything that TXA does, it happens in that first 3 hours from bleeding. Well, they smartly planned a pre-planned analysis, and even there, no difference in mortality in the patients who had a 3-hour onset of bleeding versus more than that. We do have to think about GI bleeds. When does it start? Is it when you see it? Is it when it actually comes out? Is it when it first, that little clot starts to pop? When is it? But they also, in their other pre-planned analyses, location and liver disease, didn't see any mortality benefit in this group. The only reassuring thing about this trial in my mind is that all of their safety events had no significant difference. And even the sniff test doesn't tell you that there's actually a trend towards harm. So maybe it is true that much like Keppra or a statin, probably TXA needs to be put in the water supply for us, because it seems pretty safe no matter what you give it for. The challenge of this study, and the detail you have to know, is that these patients weren't particularly sick. Only about 2/3 of them did get a blood product, and of the 67% that got a blood product, the average amount transfused was 3 units, which is sizable. But let's be clear, this is not the, classic EM sphincter tightening GI bleed that you are nervous about, that you're considering airway management, MTP, anything like that. And so what you're seeing is that this was a moderately ill group of GI bleeders, I would argue, overall. And so that has really changed my approach to this. And so when I asked you at the start of who doesn't love TXA, God, I still love me some TXA. And I want to be clear, am I giving it for the run-of-the-mill GI bleeder? Absolutely not. Whether they're coming in to the floor or the ICU, those people don't necessarily get it. But TXA is unquestioningly a port in a storm. And so I'm still probably going to give TXA to any GI bleeder that I'm massively transfusing for their GI bleed, in part because realistically, I think of 3 things. And this is a bias, admittedly, this is our own opinions, but one, those GI bleeds, I have a feeling, or at least most of them that I've ever seen, tend to happen acutely, right? They weren't just spitting up a little bit of blood and then, bah. These people start spitting blood mixed with pea soup, like immediately, right? With an AVM ruptures or a varice rupture. So I'm still a big fan of TXA in the GI bleeding dying patient, but otherwise probably not a worthwhile tool for us for just all comers in GI bleed. Now, let's change from the other side, from management to diagnosis, right? We, as a specialty, have embraced the tag. I mean, it's been around for like 40 years, but it's really made a comeback in the last couple of years. Why? Number one, at ATS a couple of years ago, the American Trauma Society platform presentation of a single institution randomized controlled trial of trauma patients showed a mortality benefit in patients resuscitated using thromboelastography versus patients using kind of conventional MTP or massive transfusion protocol therapy. That's good enough for me as a reason to use it. But let's be honest, we're EM. We love it because we can compare it to alcoholic beverages, right? That's why we love it. When you look at TAG, it's an easy sort of thing to look at. It's a graphical representation of things that we know are happening in the clotting cascade. Then along comes Didactic this year. This was published in the Journal of Intensive Care Medicine. Didactic was a multinational randomized control trial that was described as a diagnostic trial, but I'll take issue with that in just a minute, looking at randomizing traumatically injured patients to viscoelastic testing, either ROTEM or TEG, the two proprietary platforms out there, versus conventional clotting therapy, or conventional clotting tests, which are things like INR, PTT, fibrinogen, things like that. So randomized control trial looking at these two against each other and whether or not these traumatically injured patients were alive or free from massive transfusion therapy within 24 hours. And that's my issue. This is a composite outcome that we all know makes it a little bit softer. It makes me a little bit worried about actually, and they did not parse those things out in their discussion at all. And to me, I care about alive. I care a little bit less about MTP use, quite honestly. So I'd like to see that data split out, but not, this is kind of the crux of it. Their primary outcome was survival at 24 hours. What you see here is the red line is the viscoelastic testing group. The blue line is the conventional clotting time assays. And then the obviously lighter colors are the 95% confidence interval. What you can see here, though, is about a 5% difference between the two groups, which they did not, was not statistically significant at all. But when you carry that through to the 90-day survival, the 5% pretty much stays, not surprisingly, because you don't die of bleeding at day 80, you die of it at day 0, right, or day 1. And so, while this was technically a negative trial because there was no statistically significant difference between these two groups, I think there is more to be done here. There is way more testing to be done because, again, they wrote this trial like a diagnostic trial. And at the end of the day, it was a therapeutic trial, because realistically, they had designed an algorithm to respond to what they see on each of the platforms, either ROTEM or TEG, the viscoelastic testing, versus the clotting assays, the traditional clotting assays. And so this, honestly, in my opinion, was much more of a therapeutic trial of about 400 to 500 patients of how they approach their resuscitation rather than actually a diagnostic trial saying, is TEG definitively better than conventional clotting times? And so at the end of the day, who doesn't love TEG? I still love it, gang. The TEG, the graphical representation and the speed at which you can get this data in the trauma bay or the acutely bleeding patient's room is incredible, because at this point, this is essentially a point of care test. And so, there's no question, even in the Didactic trial, patients that did get treated with blood product or clotting products, FFP, fibrinogen, concentrate, something like that, all got it on average about 50 minutes faster in the group that was on the TEG group versus the group that was in the conventional clotting time. Because I don't know about you all, but it takes like a good 2 hours to get a fibrinogen at my center. So, you know, this I think has merit, and I'm not going to throw the baby out with the bathwater just because there was a negative trial. So last but not least, let's talk about vaso, right? And who doesn't love vaso? If you don't love vaso, let me tell you, you should get on the vaso train. Why? Because this is a potent vasoconstrictor that is incredibly effective at shunting blood away from non-essential organs to essential ones. There's a reason it's the second-line therapy in septic shock per most surviving sepsis guidelines, or it's reasonable to be, in part because it also works through a totally different receptor mechanism than most of our sympathomimetic drugs like Morepi. Furthermore, trials like Vanish have shown us that unquestionably, this is a pretty friendly drug to the kidneys compared to most of our other vasopressor requirements. There's no question, in my mind at least, that there's a reduction in the amount of damage to kidneys, in part because the vasopressin in the afferent arteriole actually vasodilates it. It has a paradoxical effect compared to the rest of the body. And so it certainly keeps blood flow into the kidneys. And while a lot of people don't always care, AKI is one of the biggest independent predictors of mortality in the ICU compared to almost any other sort of failure rate. Last but not least, it is right heart friendly. And gang, maybe I'm among friends who all love the right heart like I do. I firmly believe the right heart is the most underappreciated organ in the body. It is a totally separate organ than the left heart. We have to understand that. And the beauty of vasopressin is there's no vasopressin receptors in the pulmonary circulation, which means you get a ton of SVR, or systemic vascular resistance, without any PVR, meaning it's really easy on the right heart. And the right heart is essential for us all. And so I'm a big lover of vasopressin. And like everything in 2020, did someone come along and ruin vasopressin for me? I'll tell you, no, they did not. This is the AVERT shock trial. This was done at a single center in the United States. It published just this year in JAMA, or last year in JAMA Surgery. This was a randomized controlled trial of trauma patients receiving what their trigger for MTP was, which was up to 5 or 6 units of blood product resuscitation. The one group got placebo. The other group received vasopressin at a set it and forget it kind of rate, at least initially, for 48 hours, okay? And then if they met certain MAP goals, they were able to titrate the vasopressin. But this was set at a 0.04 unit per minute rate, which is pretty typical as a starting dose for vasopressin. And what did this group find? They found that their primary outcome was pretty darn impressive, which was a near halving of total amount of blood products transfused in the vasopressin group compared to the placebo group. Not only that, when you look at the per protocol analysis, which is what I prefer to look at least in this case, when it's a small trial like this of only 100 patients or so, the people that actually got vasopressin did wonderfully. They reduced all of their blood products, and all of the secondary outcomes trended towards pretty impressive. None of them are significant, but again, it's a small trial, so it's hard to get significance at this point. But you can see urine output was improved. Mortality looked improved, but again, not statistically so. So what does that mean? It's time to get on love with vasopressin. I am not saying to you that you should be using vasopressin in the real time in the trauma bay. But I am saying to you, if you are in a resource limited setting, emergency department, and somebody comes in hemorrhagic shock and you've only got 2 units of blood and there is an hour transport to wherever, I would probably hang vasopressin just based on this data alone. And I'm going to start advocating it even in my massively injured patients until we see a little bit more of a bigger trial. So ultimately, what did we learn about hemorrhage today? We learned that love is love, okay? And the things that we love can't be knocked off by trials of 2020, right? And so the HALTED trial essentially told us that TXA probably isn't useful in the moderately GI bleeding, but it is a great port in the storm for the dying GI bleed. The Didactic trial says that TEG doesn't save lives, but what diagnostic test does at the end of the day? Avert shock. This one's an interesting one. Get on board the vaso train. Again, I'm not saying replace your transfusion goals with vaso. I'm just saying that if you need something additional, vaso seems like the good place to start. And the last thing I want to highlight to y'all is we've got to love the clotting cascade, because in 2021, we've got to become the masters of the clot, right? Surgeons have abdicated this responsibility. They are less and less interested in this. And we, unfortunately, PTSD aside from like med school clotting cascade, have to know this cold and how to manipulate it, because we've got lots of choices in today's world. So that does it for us. I hope that this was a lively discussion of some interesting papers that you may or may not have seen. If you do have any questions, I think we have a little bit of time to sort of wrap up here, and are happy to take them. Okay, we're out of time. But you can also take a photo of this QR code on your phone and can go right to some of the papers in the presentation in a Dropbox.
Yeah, thanks, Matt. Unfortunately, we're out of time. We're 1 minute over. Otherwise, we'd love to discuss more, but our emails are there. You can reach out to us individually if you'd like. We really thank you for your attention.
And appreciate you spending some time with us. Continue to resuscitate in an evidence-based way.